The microlink system contains 7 instruments, the first being the trapezial pin. This allows joysticking to the trapezium for complete excision. The suture passing drill bit, which has a coined end as well as a nitinol loop. Next, the radio opaque microlink all suture button with 2 number 2 suture arms that are spliced at one end to allow for passage. The microlink backstop, which comes preloaded on the loader. The McGlamory elevator, which allows for soft tissue elevation off the trapezium to allow for easier excision of the trapezium in block, and a CMC drill guide with or without paddle. The one shown here has the paddle that's placed at the base of the thumb metacarpal to allow for easier alignment for guide pin placement. Moving on to the surgical procedure, the skin incision is made in a curvilinear incision along the glabrous skin edge where the hair stops along the palmar aspect of the hand. Sharp dissection is made down to the thenar musculature. The thenar musculature is peeled off the capsule, exposing the capsule. The capsule is incised longitudinally, exposing the CMC joint. A sharp dissection is made around the trapezium. The trapezial pin is inserted into the trapezium to allow it to be used as a joystick to circumferentially dissect sharply along the trapezium for excision of the trapezium as one piece. The McGlamory elevator again is used to elevate the soft tissues off the trapezium. Once the trapezium is completely removed, the flexor carpi radialis is checked to be intact and not transected. In this view, you can see the trapezoid, the base of the index metacarpal, as well as a scaphoid with complete excision of the trapezium. So in this technique, the drill guide is not used and a freehand technique is utilized. The starting point for the drill is placed on the proximal radial corner of the thumb metacarpal. The drill bit is then aimed dorsally to penetrate the dorsum of the hand in between the index and middle finger metacarpals. Care is made to avoid impalement of the extensor mechanisms with the drill bit. Placement is confirmed with fluoroscopy. An incision is made along the drill bit. The drill bit is then driven further out the dorsum of the hand. At this point, a loop is passed through the nitinol loop of the drill bit. It is pulled through the thumb bone tunnel as well as the index bone tunnel and out the dorsum of the hand. This allows passage of the radio-opaque microlink all suture button suture bridge from the index metacarpal to the thumb metacarpal. The loop is then used to pull the spliced aspect of the suture bridge through from index to thumb metacarpal. This results in the all suture anchor being placed at the flare at the base of the index metacarpal. The spliced aspect of the suture button is then removed. The 2 number 2 suture arms are then passed through the preloader, and the microlink backstop is then placed at the base of the thumb metacarpal. Tensioning is then performed. Care is made using fluoroscopy to confirm 1 to 2 millimeters of separation between the thumb and index metacarpal to prevent abutment of these 2 metacarpals. Next, a minimum of 5 throws of provisional plus 4 additional throws is required to ensure fixation of the microlink system. However, additional throws up to 10 throws can be helpful in burying the knot at the trapeziectomy site. Once complete, axial loading shows the stability of the suture bridge with no abutment of the thumb metacarpal on the scaphoid. Lastly, the capsule is closed using 2 vicryl.